if we parse out the comorbidities, and the three that you mentioned, and there are others, but let's take these three. There's diabetes, there's peripheral vascular disease. I forgot the third. Of these three, neuropathies, but of course that may be a subset of diabetes. Is there a difference in the way you care for these wounds? Do you approach them differently depending on their core etiology?
Absolutely.
How so?
If you have a patient, well, first and foremost, you have to do a complete history and physical evaluation. You have to go through all of the points as far as looking at them as a whole person, not just a hole in a leg. But if a patient has diabetes, very often the mainstay is to take pressure off of that wound, very often with a total contact cast or some other type of offloading device. If a patient has venous disease, the mainstay would be compression. If they have peripheral arterial disease, then you would have them seen by an appropriate specialist. So there are overlaps, but certainly every condition has to be viewed differently.
If I heard you correctly, some of these approaches are antithetical to others. One is a compression, one is take pressure off. So it really is important to understand the etiology and what's causing this ulcer in the first place. So, one, do people understand that? And two, I think I know the answer to this, it's scaring me. Are there places to go to look for the protocols to how to do it? Is there some place with protocols are us that you can go to and say, here's what I'm supposed to do? You're laughing. Is that because there aren't any?
No, I mean, certainly I think there's evidence-based guidelines, but even in that realm, I think the evidence isn't strong, and the studies just haven't been done for providers to know what is the most effective treatment option at point A, B, C, D. I think there's a lot of controversy among practitioners on what you should do and when. So, you know.
You know what I hear among my colleagues? These are reasonably smart people. I'm the lone outstanding idiot in the group. But they see somebody coming in with diabetes with a wound, and they say, I'm going to fix his diabetes. I'm going to make his sugar better, and that'll heal the wound. It seems to me, based on what I'm hearing here today, not so much.
Very interesting you say that. So if you ask the average generalist or even a diabetologist, they will tell you, well, I'm going to look at their hemoglobin A1C. I'm going to make sure their lipids are appropriate. I'm going to make sure their hypertension is controlled. And we'll send the patient to a vascular specialist, and the wound will get better by itself. So they really don't understand the ramifications or the protocols. There are dozens of guidelines, and those guidelines do overlap. Depending on what part of the country, what part of the world. Standardization really is often regional or local. Sometimes it's even community-based.
Wait, are you trying to tell me that for the purpose of guidelines, an ulcer in a diabetic in Houston is different than an ulcer in a diabetic in Portland, Maine?
It could be treated differently.
Yes.
Does
that make sense?
I'll go one step further. If a patient and I don't want to get too far ahead of ourselves here.
Go ahead.
But if a patient is going to a wound care center, as an example, to be treated, the care they get on a Monday may be very different than the care they get on a Thursday, depending on what clinician is there.
So it's personnel driven.
It's personnel driven, it's knowledge based.
It's expertise driven as well.
It's expertise driven.
Because if they see a center of excellence and then they're discharged for home care, many times in the managed care environment, the quarterback, let's say, for that wound care is no longer the specialist that treated him at the outpatient center. It's now the internist who is the gatekeeper for the outpatient care. So now that patient goes home and is treated by home health with a different set of orders.
You know, with apologies to my friends in the Southwest, this sounds like the Wild West. It's crazy that we have protocols for lots of diseases. Why are wounds so different? Is it because no one's paying attention or haven't paid attention? And why not?
They overlap a lot of different providers. General surgeons can treat wounds. Nurses can treat wounds. Physical therapists can treat wounds. It's the lack of coordination of care to be able to implement a standardization protocol that appears to be the largest problem.
Wounds are like soup. Everybody likes to take a turn stirring the pot.
That's a
and-
rather distasteful analogy, but
yeah.
let it pass.
But there, to the doctor's point, there is a multiplicity of individuals who are involved in wound management with various skill sets and area of expertise.
And let's go back. Let's go back to this this fact that wounds are a harbinger for ultimate mortality. If you think about it, so how do you study better these chronic wounds, particularly decubitus ulcers or pressure ulcers, right, which tend to happen in the elderly population? Your patient base for study may not be around long enough for you to really understand what worked and what didn't. So perhaps that's part of the quandary on why we don't know how best
Because
to
these
treat
wounds
these.
are often in elderly people with
And we can't
eventually,
follow 'em.
more rapidly than not, lethal problems.
Right.
There also is no true specialty in wound management. So if you go to a breast center, as an example, you're going to have someone who's board certified and who has an expertise in that area. We have boards in wound management, but again, there's such a diversity in care that very often we don't have that level of expertise that
All
you're
right.
seeing in other areas.